Welcome everybody to this Enter-Asthma webinar. I invite you to have a look at our website from Enter-Asthma GAA to have a look at all the webinars that will be produced in the next month. I think we had many people attending last year webinars. I think it's been very popular, and thank you so much for all your questions. So we're lucky this morning to have as a speaker Professor Jonathan Bernstein from Cincinnati, USA. Professor Bernstein is the president-elect of Enter-Asthma, the Global Asthma Association. He's a specialist in allergy and clinical immunology, professor of medicine at the University of Cincinnati. And he has done, in addition to his clinical and educational tasks, a lot of research, in fact, on occupational environmental exposure, different allergic conditions. And he has, in fact, an extensive experience in conducting clinical therapeutic trials. He published over 300 peer-reviewed articles on a variety of topics in allergy and clinical immunology, and has contributed to many book chapters in addition to edit some of these books. So currently he is the editor-in-chief of the Journal of Asthma, and I will not mention the many awards that he got during his career. So today, Dr. Bernstein will speak about some recent guidelines on asthma. Thank you so much for being with us this morning, Jonathan.
Well, thank you, Dr. Boulet. Let me share my screen. And there we go. Okay, so yes, as was mentioned, we'll talk today about comparing GINA and the NHLBI guidelines. And these are the objectives: to define the recent GINA recommendations for asthma, determine differences between GINA and NHLBI EPR4 guidelines, and describe the potential difficulties in implementing GINA recommendations in the United States, and also EPR4 recommendations, I should say. Now, just to begin, the GINA was first published in 1993, and we're in collaboration with the NHLBI and National Institute of Health and World Health Organization. Now it's an individual. Now it's an entity of unto itself. But the objective at that time was to improve the prevention and management of asthma worldwide. Now, it's a living document, as the GINA Science Committee updates the asthma guidelines annually, and the 2019 report's goals were to reduce the risk of serious asthma-related exacerbations, to avoid patient reliance on quick relief medication, and to update asthma treatment goals. Now, in contrast, the United States NHLBI guidelines had not been updated since 2007 until the recent EPR4 guidelines have been published. Now, it's important to mention that GINA is not a guideline, but an integrated evidence-based strategy focusing on translation into clinical practice. The recommendations are framed. They're not as answers to isolated PICO questions, but as part of an integrative strategy in relationship to the GINA goals of preventing asthma deaths and exacerbations, as well as improving symptom control, current understanding of underlying disease processes, human behavior of health professionals, as well as patients or caregivers, and implementation of these objectives or goals into the clinical practice, and recognizing the global variation in populations in the healthcare systems and medication access, which can be an ongoing problem. Now, the NHLBI guidelines, I mentioned, had not been updated for quite some time, and the most recent guideline were focused on key questions. And the questions they addressed were, how should exhaled nitric oxide be used in clinical practice? What is the advantages of allergen mitigation? How should inhaled corticosteroids be used in clinical practice? The advantages of increasing doses versus using other add-on therapies. How should LAMAs be used in the treatment of asthma? And then the role of immunotherapy, as well as bronchial thermoplastic. The technical manuscripts for each question are published elsewhere, and this is listed here in this slide, and it's also, you can find it in the reference listed below, which is, the focused updates on asthma management guidelines. And I think it's interesting to see the process of what went on to come to generate the conclusions that they made for their guidelines, for this guideline. However, they didn't address a number of different topics that are very important in the management of asthma, and they felt there was insufficient evidence to do so, such as the importance of adherence and how to improve adherence with medications and asthma action plans, the heterogeneous nature of asthma, the role of biologics, and there are now a number of biologics that are available to treat different asthma phenotypes. Biomarkers, except for ENO, and there aren't that many biomarkers, unfortunately, presently to further characterize asthma other than ENO and maybe peripheral blood eosinophils. Classification of asthma severity, long-acting beta agonist safety, physiologic assessments, prevention of asthma onset, a whole host of other things, stepping down from maintenance therapy, what's the role of community healthcare workers in asthma management, so that none of this was addressed in the guideline. Now, when I want to just give a couple slides on what the GRADE approach is for development of evidence-based guidelines. And there are several advantages of using this approach, this methodologic approach for classification of the level of evidence and strength of recommendations. For example, it provides separation between quality of evidence and strength of recommendation. It allows the ability to downgrade or upgrade evidence based on methodologic criteria. It provides consideration of the relative importance of various outcomes to patients who are important stakeholders. It also assesses the values and preferences in association with making recommendations, and it also provides a clearer understanding of the implications of what is meant by strong and weak recommendations. And this is basically a pictorial of the process of the GRADE approach. And yet, we're not going to go through this in great detail, but you can see that it's quite an elaborate, time-consuming, expensive process to really generate the types of guidelines that are intended. It starts off with a PICO question, where what is the problem, what is the intervention, what is the comparator, and what's the outcome? And basically, it requires a deep dive into the literature and critiquing the literature and looking at the rate of quality of evidence for each outcome and rating that, and then upgrading or downgrading based on these based on the quality. Is there bias in the data? Is there inconsistency? Is there, a number of different factors go into downgrading versus, what's considered, what makes it a particularly great study. And the grade then leads to the overall quality of evidence across outcomes based on lowest quality of critical outcomes. And the recommendations then would be we recommend versus we suggest, depending on the level of evidence. And again, recommendations for or against are made, and they're also labeled as either being strong or conditional versus weak in terms of depending on the strength of the literature. And again, it considers the quality of evidence, the balance of benefits, harms, values, and preferences, and so forth. So resource utilization, what is the cost of the treatment as well? So this is what goes into GRADE methodology, and this is becoming more of the standard in development of guidelines. Again, this just shows you the classification, and just as an example, for instance, what is a strong recommendation? Desirable effects clearly outweigh undesirable effects, whereas a weak recommendation would be desirable effects and undesirable effects are closely balanced. Now, this compares the most recent version of the GINA guideline on the left and the NHLBI guideline on the right. And you can see these are both for adults and adolescents 12 years of age and older. And the GINA on the left, actually, if you look at the boxes, they're proportionally enlarged to represent the size of the population that is characterized. So, for example, when you look at patients who have mild asthma, they make up quite a large number of the patient population. Again, looking at step 2. So what are the differences? Well, we're going to try to hone in on this, but if you can see, for instance, GINA, it looks at assessing the patient, which is very important, confirming the diagnosis, if necessary, looking at symptom control and modifiable risk factors, including lung function, looking at comorbidities, looking at inhaler techniques and adherence, patient preference and goals. And then as we are seeing these patients longitudinally, there's an adjustment where it means we treat modifiable risk factors and comorbidities. Again, non-pharmacologic strategies are used to help improve adherence, and certainly asthma medication should be adjusted up or down depending on control. We want to continue to educate and provide skills training to our patients. And finally, the review responses, which are important at every visit to look at symptoms, exacerbations, side effects of the medications, lung function, and patient satisfaction. And this goes with every type of patient, whether it's a mild intermittent, mild persistent, moderate, or severe or very severe patient. And you can see that they have listed here very early on in the course of disease is the recommendation to use asthma in patients with mild disease, mild intermittent disease or mild disease, to use as, for instance, step 1 would be as needed low-dose inhaled corticosteroid in combination with Motorola, which is a long-acting bronchodilator that has a quick onset of action. There's other options. One can use low-dose inhaled steroids taken whenever a patient uses a short-acting beta agonist. So this is a critical difference between the GINA guideline and the US guideline, where you can see in step 1, it's just still using as needed short-acting beta agonist. And then as individuals' asthma severity progresses in step 2, daily low-dose inhaled corticosteroid or as needed low-dose inhaled corticosteroid for Motorola. Again, this doesn't preclude, this precludes that patients are being monitored over time to make sure that they're doing well clinically. Other options could be daily leukotriene modifying agent or low-dose inhaled steroids taken whenever a short-acting beta agonist is taken. And you can see that in step 2, this is a little bit different than the GINA guidelines, where there's daily low-dose inhaled steroids and as needed SABA or as needed concomitant inhaled steroids and SABA. So, and then they also recommend an alternative, be a leukotriene modifying agent, but also possibly cromolyn, nidocromil, xyluton, theophylline is still recommended, where these are not recommended for GINA guidelines. And again, as we move up, we see that we now merge into the low-dose inhaled steroids LABA for the step 3, and then we go up to medium dose for step 4, and then high dose for step 5. And then we start talking about biologics with respect to the GINA guidelines. And then the US guidelines, and what's important to mention in the GINA guidelines, but as the as-needed medicine, they recommend something called SMART therapy, and we'll talk more about that, single maintenance and reliever therapy, where patients can use low-dose inhaled corticosteroid Motorola as their for prescribed maintenance, as well as reliever therapy, so that if they can take more of the medication if they still have symptoms when the maintenance therapy is not effective. This is not initiated or recommended until patients achieve step 4, start the SMART therapy. Well, actually, step 3, I should say, where they actually would recommend a low-dose inhaled steroid for Motorola, and they also recommend a daily low-dose. There are other alternatives as well. But the step 4 in the US guidelines is really where they start advocating the SMART therapy, whereas in the GINA guidelines, they recommend as needed low-dose inhaled steroid for Motorola from step 1 all the way through step 5. So big difference there between the guidelines. So let's this is just taking a closer look at the GINA. And I think we've mentioned most of the points here. It's a busy slide, but the important thing to point out is that as needed, low dose inhaled corticosteroid formoterol is taking preference over short-acting beta agonists. We're trying to get away from short-acting beta agonist use in patients with asthma. And as we get up to the higher step 4, you see that we now has an alternative add-on tiotropium, which is approved for asthma, or add-on leukotriene modifying agent. So it becomes whether we use high-dose inhaled corticosteroids or do we use medium-dose inhaled steroids with LABA, this is what's recommended as first line, but one could use alternatively high-dose inhaled steroids. Now, when the high-dose inhaled steroids LABA combination are not helpful or not working, and these other therapies, other add-on therapies have not been helpful, such as possibly triple therapy with a long-acting muscarinic antagonist, then we have to think about biologics. And the GINA guidelines does talk about the biologics such as anti-IgE, the IL-5 or IL-5 receptor antagonist, and then the IL-4 alpha receptor antagonist. Now, the U.S. guidelines also does consider the biologics. You can see that when we get up to step 4, it's daily and as needed combination median dose inhaled corticosteroid formoterol is when they start. They start looking at this. I mentioned in step 3 because they look daily and as needed combination in step 3, but they do this throughout. Up to step 6, but here they have an extra step where they look at daily high-dose inhaled steroids LABA plus oral corticosteroids that they say can be used in these patients, and but then consider adding asthma biologics. And then in step 5, the daily medium high-dose inhaled corticosteroid LABA, adding on a LAMA, but also considering high-dose inhaled steroids or leukotrienes antagonists as an alternative as well. So some similarities agree between the guidelines, and I think both guidelines agree that it's important to assess asthma control and risk factors for future exacerbations, address modifiable risk factors such as using inhaled steroids more frequently, improving control or medication adherence, ensuring proper device use, preventing overuse of SABA, reducing indoor and outdoor exposures to allergens and air pollutants, and assessing lung function with spirometry before and after starting control therapy every 3 to 6 months initially, but once stable, every 1 to 2 years in all asthma patients. Now, I'm just going to talk briefly about the NHLBI other questions that were addressed, for instance, exhaled nitric oxide, and they made several recommendations which are listed here, and most of these are conditional in terms of strength of recommendation. 2 are conditional and 2 are strong. Most of them are low in terms of certainty of evidence, and 1 is moderate. So, for instance, the first recommendation, individuals aged 5 years and older for whom the diagnosis of asthma is uncertain, using history, clinical finding, clinical course, and spirometry, including bronchodilator responsiveness, testing, or in whom spirometry cannot be performed, the expert panel recommends the addition of ENO measurement as an adjunct to the evaluation process. So it is recommended as an adjunctive diagnostic tool, but not as a diagnostic tool per se by itself. And again, that's the strongest of the recommendations. The other recommendations were for instance, we're saying that you can't use this to predict future development of asthma. You should be, you can use this. You should not use it in isolation to assess asthma control, but you can use it as part of an ongoing monitoring and management strategy. And you should use it as part of the ongoing asthma monitoring strategy that includes frequent assessments, but not as a tool for diagnosis of asthma. So I think that this is encouraging. We feel that this test is useful as an adjunctive tool in assessing these patients with asthma. We know some patients with asthma have high ENOs, and they respond to some treatments better than others. So this is, I think, I think adds to the current our current understanding and use, and hopefully it'll current use of this tool, and hopefully it'll improve it. This is just showing the cut points for what's considered normal, moderate versus high, and how it correlates with different clinical conditions. So a low ENO could be reflective of recent or current corticosteroid use, or an alternative diagnosis. Maybe the patient doesn't have asthma. If it represents a phenotype less likely to benefit from inhaled steroids, it might represent non-eosinophilic asthma or COPD, or an overlap. It might indicate other, like perhaps vocal cord dysfunction is something that should be considered. Certainly patients who smoke have low levels of ENOs, so that can interfere with the level. If you have moderate ranges between 20 and 50, again, one can consider other factors influencing the result. It may not be as reflective of eosinophilic asthma, but if it's higher than 50 parts per billion, then certainly eosinophilic type 2 airway inflammation is more likely. We should mention, though, that ENO does not measure eosinophilic inflammation. It's a measurement of inflammation in general, and is not a surrogate marker for eosinophilic inflammation. What about environmental control? Well, most of these recommendations were conditional and low, except for the final one. And I'll just mention that one, which states that patients who have sensitization or symptoms related to exposure to dust mites, it recommends impermeable pillow mattress covers only as part of a multi-component allergen mitigation intervention, not as a single component intervention. I think this is really all of the recommendations are recommending a multi-component allergen mitigation intervention. You can't just do extermination. You can't just do, you really need to address the entire indoor environment, which it makes it very difficult for adherence, and it can be very costly. So I think we obviously need new innovative strategies to improve indoor air quality for patients who have, allergic as well as non-allergic asthma, because a number of triggers that we aren't aware of that could be having a big impact on patients' control. Bronchial thermoplastic got very conditional, low recommendations. Again, it really recommends against the BT, and that it states that individuals 18 years of age or years and older with persistent asthma who place a low value on harms, in other words, short-term worsening symptoms and unknown long-term side effects, and a high value on potential benefits, meaning improvement in quality of life, a small reduction in exacerbations. And you might consider bronchial thermoplasty, but that's the highest recommendation they could provide based on the existing literature. And there aren't any double-blind placebo-controlled trials, obviously, with bronchial thermoplasty. These are all large case series, so that makes it difficult to really give you strong recommendations. Now, what about the backgrounds to changes in GINA 2020, the risks of short-acting beta-agonists only? And this is something that GINA feels very strongly about. The regular or frequent use of SABA is well known to be associated with adverse effects. It causes beta receptor downregulation, decreased bronchoprotection, rebound hyperresponsiveness, and decreased bronchodilator response. And it can also result in increased allergic responses and increased eosinophilic allergic inflammation, airway inflammation. So higher use of SABAs have been associated, not surprising, with adverse clinical outcomes. In fact, dispensing of 3 or more canisters per year is associated with a higher risk of emergency department presentations, and dispensing 12 or more canisters per year is associated with higher risk of death. So this is really what led to the recommendation for GINA in mild intermittent asthma, not to recommend short-acting beta-agonists, but to use inhaled steroids with a SABA as needed, and alternatively to use inhaled corticosteroid LABA as needed. Studies have shown that using 4 times the FDA-approved dose of inhaled steroid LABA have been safe. Now, again, this is not recommended by the NHLBI EPR4 work group for mild intermittent asthma, as we talked about already. Now, the step 2 for GINA recommends daily low-dose inhaled steroids, as we mentioned, with inhaled steroid formoterol as needed, or as an alternative SABA. And again, they recommend a low-dose inhaled corticosteroid with formoterol as needed. And it's important to mention that the recommendation is for formoterol, not for any long-acting beta agonist, because not all long-acting beta agonists work as quickly as formoterol, which works within 5 minutes or so. And then it also recommends low-dose inhaled steroids whenever a short-acting beta agonist is used, and or leukotriene receptor antagonist with an as-needed reliever, such as an inhaled corticosteroid or formoterol. So again, not recommended inhaled corticosteroid LABA by the NHLBI guidelines at this stage, mild persistent. So the single maintenance and reliever therapy, which is a mnemonic for SMART therapy, this is recommended for patients with 1 or more exacerbations because SMART was found to be more effective compared to using higher dose inhaled steroids with an as-needed SABA or an inhaled corticosteroid LABA other than formoterol as a maintenance with an as-needed SABA. It was more effective at reducing asthma exacerbations, reducing hospitalizations related to asthma exacerbations. And there were 2 large clinical trials, SIGMA-1 and SIGMA-2, which justified the use of inhaled corticosteroid formoterol. They compared using budesonide formoterol as maintenance and reliever therapy compared to fixed dose budesonide as a maintenance therapy and SABA as a reliever therapy in mild asthma patients. And patients who used 1 or more puffs of a SABA experienced reduced asthma exacerbations if randomized to the budesonide formoterol group versus the budesonide reliever therapy with the short-acting beta agonist reliever. Furthermore, the budesonide formoterol as needed group had about 25% less inhaled corticosteroid exposure compared to the fixed dose budesonide group and short-acting beta agonist group. So that's what led to really making recommendations. And you can see in all the studies that SMART reduces severe exacerbations. You can see that it favors using SMART. Everything shifted to the left compared to the right, where it would favor the alternative. So again, the evidence does support this therapy, and this is what led to its recommendations. So if we look at this algorithm, this is a nice algorithm that's provided that gives you a suggested initial control or treatment in adults in asthma with a diagnosis of asthma. And again, it starts off with confirming the diagnosis, looking at symptom control, and you should use patient-reported outcomes such as the asthma control test or asthma control questionnaire, which is extremely useful as an adjunctive tool for looking at symptom control. Looking at patients' comorbidities, upper respiratory disease, GI, cardiac, whatever, that would help, that might obfuscate the diagnosis or prevent better control of patients. And these underlying conditions would have to be treated in order to control the asthma better. Reviewing inhaler technique and adherence, and there are now a lot of efforts being developed towards smart devices which can track when patients use their inhaler, and that makes a big difference in terms of it seems to be making a big difference in patients' adherence and helping physicians know when they aren't taking the medications. And then you always have to recognize we're now in the age of patient preferences. We have to use shared decision making to achieve realistic goals in the management of their disease. And so, again, depending on where patients fall in this stepwise category would be where you would start therapy. But if it was a mild intermittent disease based on relatively normal lung function with reversibility, but patients were not having significant symptoms that were interfering with sleep or daily activities, and one might use as needed low-dose inhaled steroid formoterol. But if symptoms are twice a month or more, then perhaps using daily low-dose inhaled corticosteroid or as needed low-dose inhaled corticosteroid formoterol would be appropriate. And then if symptoms are most days or waking at night, more than once or more a week, then yes, you would go to use low-dose inhaled corticosteroid LABA along with maintenance, using it as a maintenance and reliever therapy as well. So, and then again, if symptoms are most days waking at night, you can see that going up to medium dose inhaled corticosteroid LABA and using it as a reliever therapy as well would be appropriate. And again, a short course of oral corticosteroids may be needed for some patients who present with severe uncontrolled asthma. So this is just looking at the studies, again, or the justification for as needed inhaled corticosteroid formoterol. It's prescribed in maintenance and reliever therapy in steps 3 through 5, or as needed only in steps 1 to 2 within an asthma action plan. And again, the recommended total dose for formoterol is 72 micrograms. That's 12 inhalations of budesonide formoterol, Turbihil, a day. So you see that, again, that dose it varies depending on the country, but the 12 inhalations is quite a bit, considering 4 puffs a day is maintenance. So you have quite a bit of room to use these medicines as needed. This with beclomethasone formoterol, which is not available in the United States, it's prescribed in maintenance and reliever therapy or steps 3 and 4, or within an asthma action plan. And again, this would allow the recommended dose up to 48 micrograms of formoterol, or 6 inhalations of beclomethasone formoterol a day. So the step 3 recommendations of GINA really are essentially unchanged, as we mentioned, and step 4 is also relatively unchanged, although xylutone and theophylline are no longer being considered treatment options, in contrast to the NHLBI 4 guidelines. And then we mentioned step 5, where one of the important points here, patients really should be referred to a specialist for further phenotypic workup to determine if they're allergic or non-allergic, if they're eosinophilic or non-eosinophilic asthma, looking at other demographic features. And then if they're uncontrolled, then they may be a candidate for a biologic. And this is really where specialists need to be involved in making sure the proper biologic is being selected for the proper patient, and should be considered in patients with poor symptom control, recurrent exacerbations while on maximum topical therapy. And again, the selection is based on the phenotype, endotype of the patient, the payer eligibility, cost, dosing frequency, route of dosing, and probably most important is patient preference. Now, there are guidelines. GINA does provide guidelines for children 6 to 11, and this is just the summary. Again, they recommend low-dose inhaled steroids with SABA, or daily low-dose inhaled corticosteroids in step 1, daily low-dose inhaled steroids for step 2, but other options, leukotriene receptor antagonist, or low-dose inhaled corticosteroid taken with a SABA. Step 3, low-dose combination inhaled corticosteroid LABA, or medium dose inhaled corticosteroid. Again, other options would be a low dose inhaled steroids plus a leukotriene receptor. And then step 4 would be a medium dose inhaled corticosteroid LABA, or high dose inhaled steroids, and certainly referral to a specialist at this point if managing difficult with experience in managing difficult asthma, of course. And then step 5, one could consider a biologic. We now also need to be very aware when we prescribe leukotriene modifying agents of the FDA boxed warning about the risk of serious neuropsychiatric events, including suicidality with montelukast. This has been identified in both adults and adolescents. It also causes nightmares and behavioral problems in children. So before prescribing, we should be considering risks and benefits and should notify our patients about this boxed warning. And if they notice any symptoms or side effects of this kind after starting it, the patient should stop it immediately. Now, again, this is another algorithm which is what we used, which has been provided for determining when to add on biologic type therapy. Again, this in the severe population, and the recommendations are to consider add-on type 2 targeted biologics for patients with exacerbations or poor symptomatic control on high-dose inhaled corticosteroid LABA who have eosinophilic or allergic biomarkers or are oral corticosteroid dependent. And again, we talked about things to consider when starting these, but which patient would do best with which biologic. Again, an anti-IgE would probably be useful in a patient who has evidence of atopy. They're sensitized to environmental allergens. Their total IgE is higher, and of course, this is a drug that is dosed based on total IgE and weight, and also, of course, number of exacerbations. So good predictors would be a blood eosinophil count over 260 and ENO over 20 parts per billion, allergen-driven symptoms, and childhood onset asthma. In contrast, anti-IL-5 or anti-IL-5 receptor antagonists would be useful in patients who have high blood eosinophils, patients with more exacerbations in the previous year, who have adult onset asthma and have evidence of nasal polyps. And finally, in patients who would do best with anti-IL-4 alpha antagonists, which targets also IL-13, patients with higher blood eosinophils, higher ENOs, and then they also might be used to treat comorbidities such as atopic dermatitis and nasal polyps, for which this current drug therapy, dupilumab, is approved for. So again, one would choose one of these agents based on these criteria and use them for at least 4 months to assess response. If they seem to have a good asthma response, then one would extend the treatment for 6 to 12 months, or continue it longer. If it's unclear, maybe extend it for a longer period of time. But if it's not, if they don't seem to be improving, they're still having exacerbations requiring bursts of oral corticosteroids or having increased symptoms, and consider switching to a different type 2 targeted therapy. So again, this is we've already reviewed this slide, which really illustrates the NHLBI guideline algorithm. This is the guideline for 5 to 11, which does have similar recommendations but except that whereas the GINA doesn't recommend just as needed SABA, the NHLBI still recommends SABA, and then it progresses to daily low dose inhaled steroids. And step 3 would be daily and as needed combination low dose inhaled steroids with formoterol, and then increasing the dose of inhaled corticosteroids with using as needed inhaled corticosteroid formoterol until through step 6. So in that regard, there's similarity between GINA guidelines. Again, they also recommend other therapies like theophylline, which are not recommended by GINA. And so forth. And there are other alternatives that one can use depending on the patient's preference. And then there are also recommendations made by NHLBI for 0 to 4 years of age. And again, using as needed beta agonists in step 1. Step 2 is daily low dose inhaled steroids and as needed SABA, and then increasing the daily low dose inhaled corticosteroid LABA and PRN SABA, or daily low dose inhaled steroids with montelukast, or daily medium dose inhaled corticosteroid with as needed SABA. And then again, increasing the dose of inhaled steroids for step 4, step 5, and then oral corticosteroids, but they do not recommend any inhaled corticosteroid with formoterol as an as needed therapy again, montelukast has been recommended as alternatives in this population. So there are recommendations for inhaled corticosteroid use, and most of them are conditional with low to high evidence. But the strongest one is the one with strong and high evidence is that individuals aged 4 years of age and older with moderate to severe persistent asthma, the expert panel recommends inhaled corticosteroid formoterol in a single inhaler used as both daily controller and reliever therapy compared to either higher dose inhaled corticosteroids as daily controller therapy and SABA for quick relief, or same dose inhaled corticosteroid LABA as daily controller and SABA for quick relief. So again, this was very strong, very high for ages 12 and above, and moderate for ages 4 to 11. So in that case, there's some synergy with GINA guidelines and how they recommend this therapy. What about long-acting long-acting muscarinic antagonists? And again, the certainty of evidence is moderate. The strength of recommendations are conditional. And again, it recommends against adding LAMA to inhaled corticosteroid compared to LABA to inhaled corticosteroid. So LABAs are preferred over LAMAs when you're adding a second agent. In contrast, this may not be something that you can do, and somebody who has palpitations or heart racing, maybe using a LAMA over a LABA might be a better option in those subsets of patients. But overall, LABAs are better bronchodilators than LAMAs. And then if a LABA can't be used, again, you can use the LAMA. And then again, it recommends adding LAMA to inhaled corticosteroid LABA compared to continuing the same dose of inhaled corticosteroid LABA in patients who have uncontrolled persistent asthma. Immunotherapy for NHLBI EPR4 guidelines, they have conditional moderate recommendations, and it should be used as adjunctive treatment to standard pharmacotherapy in those patients who asthma is controlled at the initiation, build-up, and maintenance phases of immunotherapy. And this would be for mild to moderate allergic asthma. And in patients with persistent allergic asthma, it conditionally recommends against the use of sublingual immunotherapy, and they felt there was not enough evidence to support this recommendation at the time these guidelines were generated. Now, there are some particular problems instituting SMART in the United States, and predominantly patients will run out of the medication before their next refill. Until this becomes policy and insurance companies will acknowledge the importance of using this therapy, this could create unexpected economic burden. And so we have to make sure that the guidelines that we're recommending it, that it's also used as the basis for the insurance company's decisions. So takeaway points: asthma guidelines have evolved based on understanding of asthma phenotypes, endotypes, and patient behavior. SMART therapy is supported by strong clinical evidence in both GINA and EPR guidelines, although GINA is certainly more aggressive in their recommendations. And many GINA guideline recommendations are off-label. So when assessing and treating patients, use professional judgment, take into account local and national guidelines and payer eligibility criteria and licensed drug doses. But both GINA and EPR guidelines should be considered in the management of our asthma patients. These are additional references to books that are great case-based books that I had the pleasure of helping to edit along with Louis-Philippe Boulet. So certainly recommend these for further reading. Thank you very much.
Well, thank you very much, Professor Bernstein. I think we had a very nice overview of these guidelines, comparative guidelines. I will have a look at the questions. Yeah, I have a few ones here. Of course, there are some differences between the two guidelines. I think the situation with short-acting beta-2 agonists is not the same with GINA compared to the NHLBI. So, of course, the clinicians looking at guidelines, they say, okay, they are based both on evidence, but of course, we sometimes interpret the evidence slightly differently. So how can you suggest the clinicians to reconcile those various recommendations? What would be your attitude in front of those two guidelines if you were a clinician in his office looking at that?
Well, I think that the smart therapy is really a major advancement in the management of our patients, and I am a strong advocate of smart therapy. I do try to educate all of my patients, mild through severe, of smart therapy, and explain to them that this is probably the best way to go, and it makes it easier. If they forget their medication and they use as their rescue medication their combination of corticosteroid for Motorola, then they're at least getting their drug and so forth. So I think that the logic, the rationale, given the data that's been out there with short-acting beta agonists for quite some time, showing that overuse is really detrimental to their overall health. I'm a strong advocate of smart therapy for mild through severe. Why they chose not to use this in the mild, intermittent, mild, persistent asthma population, I'm not clear. I wasn't in that group, but I think that the GINA guidelines, in my personal opinion, is more on target with what we need to do to manage patients more effectively.
The comment that we have is that some of the most important advances in the treatment of asthma in the last few years have been on severe asthma. And of course, the guideline, the NHLBI, doesn't touch this topic. Is it because, does it refer in fact to the very recent ATS-ERS severe asthma guideline that had been published under the first name of Holguin? Do you think it's the reason for that?
It's possible. I think when, these things have been kind of being written for the last few years, and I think they were sitting, when they made these questions, it was probably 3 or 4 years. As you know, many of these drugs are just starting to emerge as being approved by the regulatory agencies. So I don't think at the time they felt they had enough information to, and this was grade methodology. And, and I think that, even though both, GINA and NHLBI use very rigorous methodologies. I think that grade methodology can trip you up and actually delay recommendations, because it does require a certain level of evidence in the literature to. And the literature, once it's analyzed, it can result in not a strong recommendation. So I think that they prefer to delay this and to wait until there's more time, long-term experience, real-world experience with these agents, which we're now starting to see. And I think that they might have felt it was premature, and at the time they were developing the PICO questions, but again, I don't know. And I think that it's true even with the short-acting beta agonist and versus the inhaled corticosteroid long-acting, they may not have felt there was sufficient evidence at the time in that spectrum of the population to make definitive recommendations based on the literature at the time they were reviewing this stuff. So these things, the literature changes so exponentially, so fast. And that, you blink your eye and there's 20 more articles on this. And so these guidelines have to be living documents. And that's why GINA is really on target. It's a lot of work, but every year they make updated recommendations, which is essential for staying up with the management, keeping up with the proper management of asthma.
No, you're perfectly right. I think the process of developing a guideline based on grade and all these methodologies is quite a difficult. Well, it requires a lot of resources and it takes time. I took part to both this type of guideline and the GINA report, and of course, current guideline based on grade take years sometimes. For example, our Canadian guideline was reviewed about 10 years ago, and then we just had the last iteration of this guideline this year, and probably it will be outdated next year. So it's really a problem,
It's a real problem, and it takes a lot of work. It takes really experienced methodologists to be involved in this. We're trying to do this with the Joint Task Force with the grade. We have some excellent methodologists from Canada, by the way, who are working with us on this and so forth. So it's the Canadians who actually developed this methodology.
Yes, I know those. I have two small comments, two very short comments here. The one is about allergen exposure. In the NHLBI, there is a mention that if you have symptoms, you can apply all the measures to avoid allergen exposure. If you don't have symptoms, then you don't need to apply those measures. But basically, probably this exposure could cause some degree of inflammation in both cases, and could it be detrimental? It's just a matter of persuading the patient to do those, I guess.
So I think it's not symptoms, it's sensitization. So are they sensitized? So if they're not sensitized, then they're not going to be bothered by dust mite. However, they did not mention that if patients have potpourris or burning candles and incense and fragrance generators or ozone generators in their homes, or wood burning stoves or gas, or electric appliances that emit ozone. There's all types of sources of indoor air pollutants that can cause health effects that they aren't even aware of. So I think we have to have a conversation with our patients, whether they're atopic or not, about environmental exposures and how to mitigate those.
Exactly. And there was a comment about FeNO as an adjunct test to the diagnosis of asthma. I know that it's in some publication, there were some people advocating that maybe if you have a FeNO, a very high FeNO, you don't need the lung function test. I know that the most recent guideline, the ATS guideline on the diagnosis of asthma, ATS ERS, will be published in a few weeks from now. I know they include FeNO, but not as a single test, but also as in the NHLBI as maybe an adjunct test to the lung function. So do you think this is quite relevant? In fact, probably it will be consistent with the new guideline.
I think using ENO as an adjunctive tool is spot on. I don't think it should be a standalone test because there's inherent problems with any diagnostic test. The first and foremost, lung function is extremely important to make sure that people are not, losing lung function over time. We see patients who have progressive loss of lung function that have normal ENOs or that have high ENOs that have well-preserved lung function. I think that it's another tool to help us characterize our patients. We see very high ENOs in patients who have nasal polyps. Okay, so and I think there's a retrograde movement of the nitric oxide from the upper respiratory tract, which is over probably 2 or 3 logs greater in the nose and the upper respiratory tract than in the lungs. And I think we see that, and that's been looked at and reported in some studies. So we have to interpret the test properly, but it's an extremely useful adjunctive tool. I think in some of the clinical trials with biologics, for example, where they find that some of these agents like IL-4 alpha seems to respond much better in patients with high ENOs. Now, that being said, it's because IL-13 is extremely important in producing in the regulation of ENO by upregulating inducible nitric oxide synthase and the production of nitric oxide. So I think that, but we see it. Nitric oxide has no effect in patients with IL-5 receptor IL-5 antagonists. It's not a marker that would predict response. It's more peripheral eosinophils, and because it's likely not controlling the regulation of ENO, and recognize that ENO doesn't go down in those patients because it's not a surrogate marker for eosinophilic inflammation. There's a lot of inflammatory cells. That's why we call this type 2 asthma, because not only are eosinophils involved, mast cells and lymphocytes and macrophages and a number of neutrophils, a number of effector cells provide contribute to the inflammatory process in the airways.
That's right. Let me see. Okay, I know that in the past, the NHLBI had a quite huge implementation programs and developed different tools for the application of their recommendation. I guess there will be the same thing with this last one, I guess.
Yeah, I suspect. I don't know. I haven't heard much, but I think that it's out there. I really am not sure that I'm not sure, what the purpose of this guideline is, given the GINA guidelines. I think there should be some meeting of the minds to decide how to have more of a consensus approach for guidelines in asthma, only because it's going to confuse clinicians as to what to do. And I think it's an important enough disease where we develop a consensus recommendation worldwide, and to make it applicable to countries that may not have the same resources that other countries have, and so forth. So we have to be very cognizant of that. So I don't know what their strategies are, but I would recommend they should work together with GINA. Maybe you can help with that, make that happen.
That's right. Another short comment. Of course, since GINA proposed the ICS for Motorola as a basic treatment, for example, on demand for mild to very mild asthma, there are many pharma companies that develop. In fact, some have already some other types of ICS combined with the formoterol molecule that could theoretically be used. Of course, we know that all the studies have been done with budesonide and formoterol. Do you think the question is about how can we use the other ICS with formoterol the same way, or have in the United States some other inhalers become available with the other types of ICS formoterol? Or I know that there has been in other countries, but I don't know.
And of course, they'll have to go through the regulatory processes if they're going to get their drugs approved. But that being said, that I see no reason why other inhaled corticosteroids can't be used. Again, there is guidance in the guidelines about the equivalencies of inhaled corticosteroids and the doses and so forth. So one can adjust the doses accordingly to as medium, low, medium, and high doses. And then there is some guidance in GINA guidelines about the dosing recommendations for at least a couple of them, but I think that will grow as more of these therapies become available. But I see the critical thing here is the formoterol, which is the really works quickly, gives you immediate relief, just like SABA, so patients won't panic and have trouble, and they'll be able to get inhaled steroid at the same time, which will help hopefully modify the airway inflammation that's probably contributing to their exacerbations.
Indeed. I think I have a last comment to here that I think we're almost finished. The comment is a kind of speculative or philosophical. There have been discussion about the role of the components, the HFA, I guess, in inhalers in regard to global warming and the ozone layer and all that. Of course, the old propellant were quite detrimental. Now the HFA were less, but they say it's still a component of contributing to global warming, and maybe there have been discussion to find new ones or to use the powders. It's quite a debate, of course, that it's just starting, I guess. Do you have any comments about that, or is it really significant? Yeah.
Well, I do. I think that, there's multiple things that are contributing to climate change or, global warming as we see it. Probably the biggest problem is overpopulation and pollution. So, but we can't do anything about that. But certainly we are using safer inhalers, but we could always get better. We went from CFCs to HFAs. Not everybody tolerates a dry powder inhaler. Some patients don't feel like it doesn't work as well for them. And so we have to be cognizant of that. So certainly nebulizers, maybe something like a portable nebulizer that could deliver therapies. But, there's a lot of development going on with devices. These are just as difficult, if not more difficult, to get approved by regulatory agencies. They're very expensive to take through the studies and so forth. So I know it's on people's radar screens, and I think that everything has a trajectory, and we will hopefully get there.
Well, thank you so much for this wonderful presentation. I think the hour is past now. So thank you again, and I invite everybody to keep following the webinars, the Interasthma webinars. And next year you'll be the president, so you'll be involved into that. So thank you.
I think I'm being deferred on that, right? That's going to be Fulvio.
The year after, 2023.
After I'm done, yes. After I'm in the future.
That's the year I talked about. So 2023. So keep with us, and thank you again, Prof. Bernstein, for this very nice presentation.
Thank you very much.
Thank you.
Bye-bye.